arrow's not working. Maybe I need the mouse. Yep, here's our project partners. Thank you.
Yeah, of course.
A lot of the curriculum that you'll see is generated through a group called the National Task Group. And it's for intellectual disabilities and dementia practices. So this is a coalition of clinicians, doctors, social workers, all of whom on a national basis are working to improve the services, provide support for people who are living with the families that are experiencing Down syndrome alongside of Alzheimer's disease. So we thank them. We thank our host, GSAOC, our grantor, ACL, and of course, Eric and his group at UCI Mind. Okay. So today what we want to focus on in this first session, and we hope to see you all back for the second and third sessions as well, is we want to have a better understanding of the connection between Down syndrome and Alzheimer's disease. We'll talk a little bit about some of the coexisting medical conditions. We'll talk about mainly what I want to talk about is the physical and brain health habits, because these are proactive strategies that you can employ that might help to avoid Alzheimer's, or if your loved one's already diagnosed, it'll help to stabilize them. So that's kind of our agenda. So I'm going to have my colleague Eric talk about this slide if you would like to, because what you see up there are many of the common conditions that can occur in people with Down syndrome that don't necessarily mean that they have Alzheimer's, but these are things that instead are reversible.
Sure, maybe I'll come up.
Come up here, Eric.
People online are sure to hear me. So there are many, as Kim mentioned, many health conditions that occur with increased frequency in people with Down syndrome as they age that can mimic Alzheimer's dementia or even worsen an Alzheimer's dementia. One of the leading conditions would be sensory impairments. So early onset hearing loss, early onset cataracts that impair vision are quite common in people with Down syndrome. I don't know many people with Down syndrome who have hearing loss who ever say things like, "I'm sorry, I can't hear you, can you speak up?" So these sorts of issues often go missed and they don't bring them to your attention. So they don't hear what you're saying, they fake it, they pretend they heard, they answer whatever they thought they heard, they appear confused. Why are they giving me this answer, right? Are they developing dementia? But oftentimes it is hearing loss. We've had patients come to our clinic with a diagnosis of Alzheimer's, be treated for Alzheimer's, and all they need is hearing aids. So these are conditions that really need to be assessed. And these are almost all of these are part of the healthcare guidelines for adults with Down syndrome anyway. So they should be monitored at routine intervals, but oftentimes they aren't. Some of these conditions that are listed up here can mimic dementia, but are quite reversible, like dehydration or medication side effects, malnutrition and nutritional deficits, and then pain as well. So people with Down syndrome have an interesting tolerance for pain. They tend maybe not to experience pain the same way that we do, but I think as importantly, they tend not to complain about pain. So they may experience pain, but they don't complain about it. We only recognize it because there's behavioral change. And sometimes that behavioral change is just a complete withdrawal from their surroundings. So they socially isolate themselves, right? They appear like they're depressed, and they might appear like they have symptoms of dementia. And as Kim, I'm sure we'll touch on later, it's important to recognize when you think about dementia, it's not just a memory disorder. We always think about short-term memory changes. I'm forgetting where I'm putting things. I'm forgetting activities that happened that day, like what I had for breakfast that morning. But in people with Down syndrome and people without, but probably more so with people with Down syndrome, behavior change can be the first symptom of dementia.
And then in addition to the withdrawal that Eric is describing, that the opposite can happen, they can be acting out. When we see an abrupt change in behavior like that, we often think it's due to dehydration or a UTI. So, yeah.
It's important to recognize too that all of these things could co-occur with an existing dementia. So Alzheimer's dementia can be greatly impacted by hearing and vision impairments. So even though the diagnosis of Alzheimer's dementia may be accurate, it's important to recognize that these conditions can occur at any time during that course of dementia and worsen the symptoms of dementia. And as we'll learn, treating Alzheimer's dementia is somewhat limited, but treating some of these other conditions that can co-occur can lead to great benefit for the individual with Down syndrome.
So we want people to be functioning at their peak, how shall I say?
Abilities,
Status,
really,
yeah, at all times. So it's a matter of kind of tweaking some of these other things. And this happens in the general population too. For example, hearing loss is definitely correlated with dementia. If it goes unchecked and untreated, it can lead to dementia. And then, you know, infections, the presence of infections can certainly cause problems. And so, yeah, it's a lot to manage, but it's part of, you know, it's part of our responsibility as family members to make sure that people are operating well in these other areas and being treated for these common coexisting conditions.
And I guess I will add too that an overdiagnosis of Alzheimer's disease in people with Down syndrome is quite common, very common. It's known throughout the medical community that this general term, everyone with Down syndrome gets Alzheimer's. And it's an early onset Alzheimer's affecting individuals as young as age 40. That statement is true if you define Alzheimer's by the brain pathologies that are present in people who develop Alzheimer's dementia. And these are these amyloid plaques and tau tangles, abnormal protein deposits in the brain. So everyone with Down syndrome, it's been known for decades, get the brain changes of Alzheimer's at a young age.
But
they don't all develop the dementia. So quite commonly, a clinician will say any adult behavioral change or memory change, or parent memory change is Alzheimer's. So they're quickly labeled Alzheimer's. And you'll see people with Down syndrome being treated for Alzheimer's in their 20s and 30s, which has never been reported before. So overdiagnosis is common, and it's probably because of these reasons, right? The differential diagnosis is broad. Anyway.
Good. Any questions about that? All right, so we definitely want to try to rule out these conditions. We don't want to jump to any conclusions that our loved one has dementia. And even if they do, we want to control for these conditions because we know that if untreated, they're going to worsen their symptoms. I have trouble with that.
Well, I left it here.
Okay, here's more.
These are some of the other more common conditions. Hypothyroidism. I think many of you will recognize this as a common condition affecting both children and adults with Down syndrome. And I guess I will mention in adults with Down syndrome, we don't really know what the incidence of hypothyroidism is. And that's probably because there haven't been that many good, large studies on adult healthcare issues for people with Down syndrome, because people with Down syndrome used to not live as long as they do now, right? Life expectancy in the 1980s was just in the early 20s. Today it's 60 years plus. So we're only really starting to know about the true incidence of these conditions. But I would say it's probably 65%, 70% of adults with Down syndrome have hypothyroidism. And if left untreated, hypothyroidism can impair memory function and mimic dementia. And that said, even in people who are treated, people might develop early symptoms of dementia. They're independent for their medication taking. All of a sudden, they're not taking the thyroid medication. So things can get a lot worse real quick, right? Plus, that dose of thyroid medication needs to be monitored at regular intervals in anybody with hypothyroidism. And adjustments are common. So hypothyroidism is a very common one. Alcohol and drug abuse, of course, is very rare in people with Down syndrome, and some of these other conditions are extremely rare as well. Lyme disease, cardiovascular disease, and stroke. So the atherosclerotic changes that we're all at risk for with our lousy cholesterol levels, our lousy diets, they don't happen in people with Down syndrome. People with Down syndrome, despite bad lipid panels, despite bad diet, sedentary lifestyle, don't develop atherosclerotic changes in their vasculature. So they're at lesser risk to develop heart attack from those sorts of changes or strokes from those sorts of issues as well, which is quite remarkable and something worthy of study. So I think we'll go on.
Let's just talk about this one for a moment because obesity is common in our population. And, you know, in the general population, the neurotypical population, diabetes is very much a risk factor for Alzheimer's disease. I don't know if our population has.
Diabetes is a bit more, obesity is more common in
Right.
people with Down syndrome. Diabetes, type 2 diabetes is a bit more common as is type 1. Still uncommon, but a bit more common than in people without Down syndrome. But obesity, as you would imagine, affects all aspects of health. And I think most importantly would be sleep apnea.
Yeah.
So people with sleep apnea who have obesity, their sleep apnea is worse because of their obesity. And as we are starting to learn, sleep apnea is a risk factor for all forms of dementia, including
Absolutely.
Alzheimer's. And sleep apnea is much, much more common in people with Down syndrome. And there is some data suggests 85% or more of adults with Down syndrome have sleep apnea, even thin people with Down syndrome, even people with Down syndrome who don't snore. So the facial structure of people with Down syndrome, the small mouth with the somewhat larger tongue, and the laxity of the ligaments, right? People with Down syndrome are quite flexible, all contribute to this increased risk of what's called obstructive sleep apnea in people with Down syndrome. So when they relax at night, they're sleeping on their back, their airways is blocked by their tongue, and they can't breathe, and that's obstructive sleep apnea. And it's much more common in people with Down syndrome that are heavier than people that are thinner.
Yeah, and good advice for all of us too is to make sure that if we need to, we have a sleep study for ourselves. Because, you know, it's, you have to think about your health as well as that of the persons that you're caring for. Just having a little trouble advancing these. Okay. So these are some of the things we want on our checklist. We want to instill good health practices for the whole lifespan to the best of our abilities for our loved ones as well as ourselves. We want to make sure they have access to quality health care, screening and detection of Alzheimer's disease and other illnesses is important. We'll be talking about that next time. Our next session will be all about how to screen for dementia. As we've mentioned, we want to monitor and manage coexisting medical conditions. So, you know, Eric mentioned being compliant with medications to treat these disorders, and then we'll go into some of the healthcare practices too. We're going to rule out treatable conditions. We're going to maintain functioning, the activity level as much as possible, maintain good nutrition, hydration, and exercise habits, and do our best to keep a positive attitude, right? So this is sort of your checklist going forward. And we know everybody works hard and it's been a long road. And so we don't expect perfection by any means, but these are things to be conscious of. Okay. Eric, do you want to talk about the guidelines?
Sure. I'm just glancing over them now. So we're learning, of course, with all aspects of health, right? Diet matters, and that includes brain health. So both in people with Down syndrome and people without, we are learning that these healthy sort of Mediterranean diets that are high in fiber, low in polyunsaturated fats, high in some of the healthy fats like you might get from nuts and olive oils and things like that, are not only heart healthy, right? They're brain healthy too. So diet matters. I know that's difficult for all of us, but it's something we should be mindful of. Exercise is also extremely important for brain health. And it doesn't have to be marathon running and all that strenuous of exercise, just routine movement and less sitting seems to be quite important. And of course, educating ourselves about health, and people with Down syndrome can participate in that as well. Sexuality, as you all know, is somewhat less common in people with Down syndrome, especially in the age that we typically work with, people that are currently in their 40s, 50s, and 60s. I think we're going to see a big shift in that when these 20s and 30-year-olds are now aging into the sorts of ages where we worry about Alzheimer's risk. I can only think of one patient who presented with symptoms of dementia who was known to be sexually active, that the light bulb went off in the clinician's head is this syphilis. And we did a syphilis screen on the individual, which is part of the differential, right? But uncommon to consider that in people with Down syndrome. But as I said, I think it's going to be much more common as this younger generation of people with Down syndrome age. Smoking is very rare in people with Down syndrome, and I'm sure you all know. So some of those things are less of an issue. And then we've touched on weight gain and things like that. The speech and language therapy, I'll just mention DSAOC has an adult speech program here that's in collaboration with Chapman University, their speech pathology program. And I can't tell you how many times I've had parents of adults with Down syndrome come in, oh, they won't improve speech therapy anymore. You know, they're too old. They're not going to learn any new speech. And that's been proven wrong from some families that I know who have fought to get speech therapy. So I think it's nice that we've got an opportunity even here in Orange County for people with Down syndrome to receive speech therapy in adulthood. And anecdotally, so many families have told me how important that is. But they've also told me, also an activity here at DSAOC is this drama therapy. That they'll tell me, wow, their speech is so much better now, right? They actively want to communicate more now than they ever did in the past. And they link it to this drama therapy that they're giving.
Is it like improv?
So, there's multiple, there's an improv here that Tony does.
Yeah,
but then there's also drama therapy and things that have been done here in the past.
By the way, everyone, this is Tony from Down Syndrome Association of Orange County. I neglected to introduce you when I was introducing the players here. So we're happy to have you here helping us.
And as we said, the next session, we're going to learn a lot more about the early symptoms of dementia and when it's appropriate to get a referral. And I just want to mention on the last slide, we saw something about managing healthcare, right? That's very challenging for adults with Down syndrome. It's hard for families to find a clinician who, one, cares and has any experience treating adults with Down syndrome. At UCI, we have Dr. Emily Dow, who has a primary care clinic for adults with Down syndrome. We have Dr. Brian Hitt, who has a dementia care clinic for adults with Down syndrome. But, you know, we're one of the only centers west of Colorado that has anything for adults with Down syndrome. But I want to point out, and I hope it's on that resource list, if it's not, we'll add it, right? The adult healthcare guidelines for people with Down syndrome are updated 2 years ago. And those are available online to anyone, any clinician. There's this Down Syndrome Clinic to You website that any family and individual with Down syndrome can go into, enter their past medical history, and then it spits out a report. It looks at that medical history, compares it to an algorithm that includes all of those healthcare guidelines. Actually, I misspoke, spits out 2 reports, 1 report for the family, 1 report for the doctor, that basically says this is the list of things that need to be assessed in this individual, and gives them resources on how to assess those things. So even though there may be people with Down syndrome remote from us here in Southern California, there are resources out there that are available. So if that's not on the list, we'll make sure it is.
Absolutely. Are we ready? More guidelines.
So these are some of the healthcare guidelines that you'll see. And of course, they touch on a lot of the areas that are more common in people with Down syndrome, the thyroid function and things like that.
Keep speaking up there.
Yeah. I mean, you can just read through these, and as I said, those are available online, and you can download those and share them with your clinicians. Um, and sleep apnea has made its way to the healthcare guidelines for even children with Down syndrome beginning at age 4. And I think there's a recommendation to even lower that age for sleep apnea assessment. Cervical spine, I think you're all from the generation where we worried about injuries from sports accidents and Special Olympics due to ligament laxity in the area of the neck that connects the skull, and you can see excessive movement there. That can present at any age in people with Down syndrome. That's on the differential diagnosis for Alzheimer's. So Alzheimer's disease not only affects brain memory and function, it affects motor coordination. So you see a very characteristic gait in people with Down syndrome who develop Alzheimer's. You see urinary incontinence. And these symptoms present in people with atlantoaxial subluxation, where there's impingement on the spinal cord. So the neurological changes that you see in the lower extremities that affect gait, urine, and bowel control can present. And we've had some people with Down syndrome present in clinic with dementia, but it's not dementia, it's actually this condition. The current healthcare guidelines just recommend neurological exam on an annual basis to rule out that condition. And then when people with Down syndrome age, I mentioned their hearts tend not to develop atherosclerotic changes, but they are at greater risk for other conditions of the heart that involve heart valves and heart rhythm abnormalities as well. So cardiac pacemakers become a bit more common with aging in adults. I think that's all. We could go on. Good luck.
All right, so we want to begin talking about some of the sort of pillars of successful aging. And there are more than 6, but these are sort of 6 big bucket areas that we wanted to share with you. They involve diet and nutrition, exercise, as well as overall physical health, cognitive activity, social engagement, sleep and relaxation, and medical health. And so, as I mentioned before, these strategies will help them. These strategies will help you. They're thought to be, but not definitively thought to be preventatives for Alzheimer's disease. But even in people that already have Alzheimer's disease, they help. They help to stabilize. So when it comes to nutrition, this is kind of what we're looking for, but that is not the average American diet. The average American diet is heavy on fats, heavy on desserts, heavy on dairy. And in fact, we need to fill half our plates every day with fresh fruits and vegetables, healthy grains, low fat dairy, healthy proteins like chicken and fish. You know, fish is always commonly thought to be brain food. A lot of these vegetables and fruits have antioxidants, and they're just more color the better. But this is what we have to strive for. And this is hard for all of us. It's definitely hard for me, but we have to do better. And then of course, hydration, constant hydration. The body needs hydration, the brain needs hydration to function well. And you know, these are things that we know through research findings that are healthier for us. So as I said, we want to fill half our plates with fruits and veggies. We want to pack 1/4 of the plate with healthy proteins, lean proteins. And we want to give half a plate or 1/4 of a plate to, did I say a half a plate for the proteins? I meant 1/4. Okay. I can do fractions, I think. And then 1/4 of a plate to whole grain foods. So this is going to be our ideal, but because we're human and we're not perfect, we're just going to try to even make some small changes in these and other areas. So, I mean, if we try to do everything perfectly, then we kind of set ourselves up to fail. So small changes can translate to larger impact down the line. So it's just a nice guideline. And make water your drink of choice and drink lots of it. Okay, exercise, do you want to add anything on nutrition? Okay, so studies have shown that physical activity may slow cognitive decline. It's going to improve overall physical health as well as mental health. It's good for our mood and our disposition. It does reduce fall risk. I know a lot of like older adults will say, well, I'm trying to stay put so that I don't fall. That actually increases their fall risk. And then again, physical activity may improve mental health and improve sleep. So make exercise fun and social. Small improvements, as I noted, can make a large difference. The social part, I don't know, like for myself, I have a walking partner and we keep each other honest. You know, when one says, oh, I don't feel like walking, the other one thinks that, come on, get up, let's go. So anything you can do, like in terms of if they want to be in a class, yoga class, exercise class. Again, exercise is good for all of us. It helps all of us improve our physical and mental well-being.
I'll just add something
Yes.
anecdotally. All of these things too are important, even in individuals who have dementia.
Right.
So families have told me many times, you know, on the days he swims, you know, he seems a little more cognitively aware, even though the dementia is still there. Seems to be better days on the day they exercise. It's all anecdotal with regard to exercise, but many of these other things, there's documented proof that they do help treat dementia and manage symptoms.
I do see that too, that there's an improved alertness. They're more alert. So. Cognitive stimulation. So we know that studies have shown that it benefits memory and thinking. It helps to reinforce existing strengths and abilities. And again, it improves positive well-being. So we want our folks, you know, Eric mentioned sometimes people withdraw and they don't want to do their social or their cognitive activities as much. We want to encourage people to, and it takes a little bit of prompting and cueing sometimes, to engage in their usual, as much as possible, their routine, their social activities. Singing and music is always a hit. Who's our DJ?
DJ Willpower.
DJ Willpower.
Yes,
Right? We're gonna have to do an event at your place with our DJ. He is so wonderful. He'll be at the walk.
Oh, good.
Sunday. Yeah. So music is always a hit. Singing, music, games, puzzles, keep people's minds, you know, working, and have people participate in classes, hobbies, their work, continue their work, and their volunteering as long as possible. So we want to do this, but I also want to say, as kind of a caveat, when people with Down syndrome are diagnosed with Alzheimer's disease, it does mean that they're not going to continue improving on their skills. So you know, you kind of work your whole life to keep them functioning at a higher rate, you know, as you go along. We get into a place with dementia where we really want to look at maintenance of skills, not necessarily learning new things, but helping people to stay on their routine and do the things they do, but we have to simplify as we go along. So we don't want to take activities away from people because they can't do them anymore. We want to instead maybe step in, offer more supervision, and definitely, you know, ratchet it down to a level where they can continue being involved in the things they love. And some things just never go away, you know, like the music part. You can always, you know, affect people positively through music. So does that make sense? It's about kind of maintenance of functioning instead of pushing to do more. Okay, and of course, social engagement is such a major part of their lives throughout their life course. But as Eric mentioned, you know, sometimes they withdraw. due to the symptoms. So we want to make sure that they stay involved. We know that throughout the lifespan for all of us, that that social engagement is an important predictor of well-being throughout life. People who are engaged with others seem to be overall happier than those who are isolated. We don't want anybody to be isolated. Absolutely not. And we want to support their happiness and health by keeping them involved with others. And it might even reduce the risk for, some of these physical or mental status changes. And then sleep and relaxation. We know that sleep is essential to mental and physical well-being, but the other thing is our brain is working during the sleep process. It's working to help, consolidate memories, but it's also clearing out toxins such as amyloid, which is the culprit and thought to be the culprit in Alzheimer's disease. So it's important that people try to be on a regular sleep cycle. This can be interrupted in Alzheimer's disease. And so it's just, is there anything you want to add on that?
No, just to emphasize what Kim said, we really think this is the reason why conditions like sleep apnea that are affecting sleep, robbing the individual the ability to get to that stage in sleep where toxins are being removed from the brain. And some of those toxins include excess proteins like amyloid and tau that are found in brains of people with Down syndrome and people with Alzheimer's.
So, I forgot to mention tau.
Yeah, so we don't know for certain if this link is true. In animal studies, it's true, but they're difficult studies to do in humans, but there are many studies underway to uncover the links between sleep disruption and dementia, including Alzheimer's.
I want to pause for a second and ask our folks online if you're still hearing both of us well.
Yeah, one note that we got.
Yeah, we can hear you.
To stay on this side, because I think that
I can hear you.
and over there it
Okay.
kind of blocks the mic.
Oh, I'll stay over here.
Yeah.
Okay. Do we have any questions? Yes.
Which stage of sleep actually does remove that?
It's
Because there's several
a
different stages.
it's a stage of deep sleep.
Okay.
And
Like
it's
the
a stage that you're less likely to get into if you're being affected by sleep apnea.
When you follow it,
Yeah,
you can check your.
I know.
That's right, your
I know.
Fitbit.
Stages.
Exactly.
Yeah, sleep
Gosh,
is
they have
very
apps now that
important.
tell you everything you're doing while you're sleeping. Okay. Any questions for our folks online? Okay. All right, so here's some tips for a good night's sleep. We want older adults, including, of course, your kids are experiencing premature aging, right? So if they're in their 40s and their 50s, that's like our 60s and 70s. But for all of us, older adults, we really still need 8 hours sleep, okay? A regular sleep schedule is preferred, a bedtime routine. We want to watch the temperature control in the room, adjust the lighting, and encourage exercise during the day and less napping. So if people are up and active during the day, they're much more likely to enjoy a good, healthy night's sleep. So yeah, no napping in the late afternoon or snoozing in front of the TV in the evening. We don't want to they're saying don't use electronic devices right before bed. I struggle with this because my computer has replaced reading in my life, right? I used to read before I went to sleep and now I'm on the computer. So that's not good. I've got to do better. No consumption of big, heavy meals late in the day. I mean, what's really healthier is to have a bigger meal at lunchtime. And I know maybe that's not possible because a lot of your kids are working or in programs, but a heavier meal at lunchtime and then a light meal in the evening is pretty healthy. And then caffeine is not good late in the day and in the evening. And, people think that because if they drink alcohol that they're gonna get to sleep better, and they do, actually, they kind of pass out. But the problem is they wake back up in the middle of the night, and that is not healthy. So we don't recommend drinking to improve sleep. Okay, and then, we're kind of talking about the physical aspects of things, but these are things that are part of the whole successful aging for all of us, okay? These are sort of general and especially helpful for our loved ones with Down syndrome. Regular health checkups, that's for them and for you, okay? Pay attention to that hearing loss and sleep. We've been emphasizing that all morning. Also, any kind of chronic stress or mood disorders should be addressed. Medications have to be taken regularly. So I think Eric mentioned earlier, maybe your son, daughter, or sibling was always good with taking their own meds, but maybe now they're not so compliant. And of course, that there can be an inherent danger in that. Especially if there's life-sustaining medications, it's just not good to be non-compliant or out of sync with your medications. So you may need to step in and monitor that. The medication packs are helpful with the days. They even have electronic things now that say, it's time to take your meds, Kim. So, I mean, there's a lot of research around, how important this aspect is. You want to try to avoid preventable illness. For me, that means the vaccinations and just, the health, keeping up with the health checkups and looking for signs of increasing coexisting conditions. Yes.
Question about depression because it comes up quite a bit. Are there any good resources? It seems like there's a lack of resources for helping individuals with Down syndrome. When you think there will be depression, I have the same history of depression. My son shows some signs of depression. And I don't feel like we're able to really, I talk to everybody about it, but nobody really knows how to help them. I understand we try to keep them active, we try to keep them social, but I feel like he's got this family history and I don't know how to help him and nobody really does. So what are the resources for
And
that?
I'm so glad you brought that up. So in case you didn't hear the question online, someone here is asking about, what to do about depression in their loved one. And I'm going to ask my colleague Eric to address that.
Yeah, I'm like many though, I don't have a great answer. It's a very unmet health needs for people with Down syndrome. When you think about professional counselors that they can speak with, when you think about psychiatrists that they can work with, in my view, it is the biggest unmet health need for adults with Down syndrome. Behavioral health is a significant issue. I will mention, if it's not on that resource list, the gurus in this area are the two clinicians who established an adult Down syndrome clinic in Chicago many years ago, Dr. Brian Chicoine and Dennis McGuire, who's a psychologist. They wrote a book called Mental Wellness in Adults with Down Syndrome. It's in its second edition. Brian Chicoine, MD, and Dennis McGuire. And at Advocate Health, they've made the second edition of that book free to download for anybody. It's 600-700 pages. What's nice about the downloaded version is you can do a word search.
Yeah.
And within those 600 pages, you can find just what you need there. So I would advise all families to get that book. But, I'm no expert really on this topic of depression management or prevention. But certainly a lot of these health conditions we're talking about here are not health conditions, but strategies, the diet, exercise, all matter for mental health as well, right? As just overall brain health. At UCI, we have had good success in the past. We had a 12-year clinic specifically for people with an intellectual disability and behavioral health needs funded by the Regional Center of Orange County. But that funding went by the wayside years ago. The clinician that was last staffing that clinic started a specialty clinic for 3 years at UCI for behavioral health needs in people with intellectual disabilities, particularly Down syndrome. But she got snatched up as an administrator and had to cut back on her clinical duties, and no one stepped in to take that over. There are a lot of reasons, I think, why the issues are there. There's a lack of training in adult psychiatry for neurodevelopmental intellectual disabilities, right? On the pediatric side, there's a lot of training, a lot of clinicians that are interested. But on the adult side, it's not that way yet.
What about medications, Eric?
There are medications that can be used to treat dementia, treat depression effectively. A lot of the depression in people with Down syndrome is driven by anxiety. So treating anxiety can be a help. But I want to point out too that some of the earliest symptoms of Alzheimer's disease are depression. And Dr. Lott did a study in the 1990s where they looked at people with Down syndrome who were exhibiting behavioral health issues in their 30s and followed them into their dementia risk years, into their 40s and beyond. And those that had symptoms of depression in their 30s were more likely to develop dementia in their 40s. And it's thought that perhaps those symptoms of depression are really part of the same process, the pathologies of Alzheimer's disease that are being deposited in the brains of these people with Down syndrome. And that's known in people without Down syndrome, right? Behavioral health issues in adulthood is a risk factor. Depression in particular is a risk factor for Alzheimer's dementia, but it may all be part of the same process. So as I mentioned before, everybody with Down syndrome develops the brain changes of Alzheimer's in young ages, and they accumulate throughout adulthood and reach critical levels by age 40. So decades before an expected dementia, you see these pathologies. That's true of people without Down syndrome who go on to develop Alzheimer's too. They're developing those brain changes decades before a dementia is recognized. And we don't really know how benign those early changes are, and they all could be part of the same process.
So can we circle back to medications? Because I think I'm hearing you say that if we could use anti-anxiety medication as opposed to like a depression that's typical.
It's commonly something that they'll use to treat a depression in an individual with Down syndrome. But
Let's
Oh, so basically, because I know that a lot of antidepressants, also, there are some antidepressants that also treat anxiety. So, versus an anxiety drug, most anxiety drugs are things like benzos, and we don't want to go in that direction, but for actually managing anxiety, isn't it typically certain antidepressants that also?
I don't know, and I think
I
that's
know you
where,
are medical doctors,
but I think that's what every family wants to hit on, right? What is the medications and the dosages of those medications that are shown to be more effective in people with Down syndrome.
And I'm not a big, I'm not a big fan of medications.
Right.
It's just that when you feel like you're doing everything else, you're providing social opportunities, cognitive opportunities.
How are you?
Good. How are you?
Good, thank you.
Doesn't want to even engage in some of those things, they'll say no to them. Then we're in a kind of tough situation.
You sound like a wonderful mother. Absolutely, you really do. And I don't know if this is helpful, but I tell people, families that don't have Down syndrome, that they should consult with their pharmacist, because often you can get really great advice on medications from pharmacists, and they're accessible. So I'll say that personally, I suffer from anxiety, but not depression, and I'm on a medication for anxiety that works very well.
Okay.
And, so, we want people to live their best life, right? That's the point of all the discussion that we're having today, and that includes addressing mental health issues. And I wish we had more resources in that.
Yeah, and just to clarify, you don't know of any clinicians in the area that really you would recommend?
No, I don't. The last one at UCI is no longer accepting new patients. But I will say one thing real quick. So this is something that you all should know. And if any psychiatrist who's willing to see a patient with Down syndrome knew this piece of information, it would be helpful. And this mantra is described in that book that I mentioned, and it's this notion that someone has said it's like good barbecue, right? Low temperature and you go slow, right?
Yeah.
So this starting at low dosages of any psychoactive medication in people with Down syndrome is required. So many psychiatric medications have a known therapeutic dose. Just say, for example, it's 100 milligrams. But if you start at 100 milligrams, you're going to see a high co-occurrence of side effects that are intolerable. But if you start at lower doses and titrate up slowly to that therapeutic dose, you might eliminate those side effects and get the person to a therapeutic dose. And say it's typically 25 milligrams, then you go to 50 after a week, then 75 after 2 weeks, and then you get to the 100 step. But in Down syndrome, it would be, if you can half that 25 dose, half it. If the titration schedule to go up is a week, extend it to 2 weeks. And I can't tell you how many families who have said, oh my God, I never want to touch that medication again. The last doctor put them on that medication. It was horrific. But it turns out that was the one medication that ended up working. Just, it was much lower of a dose than that 100 milligram dose. The 50 milligram dose was enough, but only if you started at the 12 and a half in that example I gave. And that, if you just took that to the psychiatrist, you're going to save a lot of time. Because for any of us, not one psychotropic med fits all, right? And it's common for people to try different medications till they find the one that works best for their symptoms and their metabolism. But that's listed in that book, and that's, to me, that book's worth just knowing that piece.
Yep, start low and go slow.
Yeah.
Miami, you had a comment.
I just wanted to share. My daughter, has been taking a long time, especially the fluoxetine, and then another one, Risperidone. And the problem with Risperidone will make you get fat.
Weight gain, right.
Has to do maybe a lot of metabolism, and so not really obesity, but she started taking that Risperidone. She started gaining a lot of weight and never can do it, and get it done. So
Thank you, Megan.
those medications, because as I have been telling you, both Eric and but if she skips, there was a time she was not taking, and that's when we had a lot of problems with a lot of Alzheimer's signs. And which is now settled with it, as long as she's been taking medications along with a few others, she's been okay most of the time.
Thank
So I think
you.
it has a lot to do with it.
So, I forget where we were here. I know we talked about
I
medication.
just added in.
Pardon?
I think we finished it. Actually, I have one other comment, that's oral health. So it's been long understood people that have had chronic gingival gum infections, mouth infections have a higher risk to develop Alzheimer's as they age.
Absolutely.
And as you probably all are aware, dental hygiene is difficult for people with Down syndrome. For some reason, gum disease is very common, and they think it relates to an immune system, a B cell issue, despite the fact they brush their teeth routinely after every meal and all of this. But to the extent that you can manage gum infections, it may be doing something to lessen the risk of Alzheimer's. And they think it's just related to this chronic inflammatory response that's being experienced by the body. But it's pretty well established that poor oral hygiene is a risk factor for Alzheimer's and other forms of dementia.
We've seen a couple of outlier type cases in the non-Down syndrome population. We had one man that was a regular flosser, and somehow a piece of floss traveled up into his sinus cavity or something and caused inflammation and infection. And he became very confused and forgetful and came to UCI Mind Clinic, the ADRC, and antibiotics was the treatment, and that was the cure, and there was no more dementia. So we just don't want any infections near the brain, right? Okay. So, anxiety. Yeah. So it can accelerate, in unfamiliar situations. So these are like environmental things that we can do to reduce the incidence of anxiety. you know, taking away control, setting our expectations either too high or too low, you know, change in routine, change in environment, transition. Sometimes people, you know, sit in a particular place every day and they come in the next day and the chair is not there and they have to sit somewhere else and that can throw them off. Right? I mean, anything, you name it. So not being able to be understood, having those comorbidities, the health issues, holidays. I don't know if anybody saw this or has been seeing this over the recent holidays, but a lot of that hustle bustle, the excess decorations, the blinking lights, the visits from people from out of town, all of that can add up to a lot of increased anxiety. A loss of a friend or a family member, you know, can cause anxiety, of course. Not being social or losing friendships, and also waiting, right? Just waiting. So these are some of the triggers for anxiety. And, you know, perhaps you see some things in there that can help you to avoid this going forward. Any questions about this? We are running overtime. That's fine for me. And are you okay?
Mhm.
Are you okay? Oh, good. All right. So remove the cause, figure out what the trigger is and remove the cause of the anxiety. Having them take slow, deep breaths, breathing in through the nose, out through the mouth. Really works good for you too. Going outside in nature, just being on the move. So taking a walk outside can be very calming. Unless you're walking by, you know, if you live by a freeway, maybe not. Giving lots of reassurance. Think about what's worked in the past and do that. And just ask them, I'm here, what do you need? How can I make you feel better? Okay, we're almost at the end, and I think we can probably just have you look at these things. You are all obviously healthcare advocates for your loved ones, and you have been. You've been fighting all along to get them the things that they need and to do all the right things. And so no one has to teach you how to do that. You're already doing it. But I think as a result of today's topic, I hope that you've learned some new ways to advocate for your loved one. You know, ruling out treatable conditions, making sure they have the appropriate treatment and support, helping them to have the highest possible level of functioning and the best quality life possible. Be that knowledgeable support person at the medical appointments. Of course, you are the informer, you're the informant. And so they need you to, you know, to share everything that's going on and particularly any changes that you're observing. Keeping open communication with healthcare providers, collaborating, monitoring those medications, as we said, watching for signs of depression or anxiety, and keeping the family included and up to date, and taking into consideration any and all religious or cultural considerations and traditions that help to ground people. So, do you want to go over this part, or do you feel like it's necessary?
Just glancing at it.
Yeah, I think.
We've covered most of it.
Yes, and we're going to go into more of this next time because we're going to talk about a tool that we can use and administer to you to assess the functioning level of your loved one and to see if there's been help make you cognizant of any changes that may have occurred. So all of this is kind of brought into that. Yeah, you know how to go to the doctor. Right. Okay. This one, let's just highlight it again. Never assume that the signs you're seeing are dementia, and don't let the doctor do that either. Remember, we want to rule out any potential treatable conditions. And so being informed about that, I think is really key, because as Eric has said a couple of times, doctors are now rushing to the conclusion that they have dementia, and then they're saying they have Alzheimer's and there's nothing that we can do, right? So we don't want to get into that trap. Keep your eyes open, assess, do baseline reporting like we're going to teach you to do next week, and communicate. All right. So in summary, secondary health problems need as much attention as the primary concerns. And we need to sharpen our observation skills, speak up, and trust our instincts. Finally, connect with services and resources. Some of the services that you used in the past may not be as appropriate now that we're in the aging zone. And so, right? It's so hard to think of it, right? It's like, oh my God, we're there, but the folks we're caring for are experiencing that prematurely. So it's like when you say, how did I get the 40-year-old kid? I'm only, 39. So connect with services and resources, and you are all invited to join our support group. So I brought copies of the slides, and I don't know if maybe I ran out of them, but we can send them to everybody. We have your information on the sign-in sheet. Please make sure you have given me your emails. And are there any questions? Here are just some of, our partner resources.
So I'll mention as well. So the Down Syndrome Clinic to you, I've already mentioned, but the National Down Syndrome Society has 3 excellent resources for adults with Down syndrome: general health care maintenance for adults, Alzheimer's booklet, as well as an end-stage Alzheimer's booklet as well. And those are free to download. I think the healthcare one's available in Spanish even.
Were any of you at the conference? Yeah, I'll put you up for a minute. Yeah.
Those are actually.
Yeah. Okay, great. So
And the medical one that Eric mentioned, the healthcare guide, they have one for families, the NDSS, as well as to give to your clinician.
Yeah.
So that's super helpful, especially if it's a new doctor.
Yeah.
Okay. Oh,
There's Down Syndrome Clinic.
There it is.
Too.
Okay.
Yeah, it's a fee-based, but I think it could be quite helpful.
Yeah. I think I like the infrastructure of that.
Yeah.
It kind of pushes you through the steps.
Yeah.
Which is helpful when you're so busy, right? Okay. Oh, that's just us. We do have on our website, which is www.alzoc.org, a page for IDD. So feel free to visit us there. And let me stop sharing. Hello, everybody. I hope you were able to hear.
Yeah, we could hear. Well, I had a quick question for you.
Okay.
When you talked about medications, what's the general sort of view regarding metformin as for depression and weight loss and dementia issues? Any view on that?
Gary, I'm sorry. No, I don't have any opinion on the use of metformin for those conditions.
I mean,
Okay.
we approve of it for diabetes.
Sure, yeah.
And
Right.
But as to how well it's going to prevent Alzheimer's disease, I'm uncertain. I know there's some information available on the internet about Alzheimer's disease.
Okay. Okay, I appreciate it. And you'll be sending the slides to all of us who are online also?
If you signed up, then
Yep.
yes, absolutely.
Okay.
Yeah.
I have a request
Okay.
for Eric.
Thank you.
Eric, it's Lissa.
Hi, listen.
I'm feeding the name of the book on, so a lot of people are asking for what the name of the book was. So I've been sending links to a couple of people, but I think that would be helpful. And the other slide I would like to see, so I can write down, it's the one after anxiety and Down syndrome. It's what you can do.
Okay.
If we could get that one back up, I'd appreciate it.
Which one?
I think Kim would be better able at doing that than I will.
Well, but you could do the book. Brian Ciccone, could you put that one up for people?
In adults with Down
What do they
syndrome.
want down? Alzheimer's disease?
And it's free at the Advocate Health website. So if you just use those search terms, you'll find it. And then, I will say, so we have a longitudinal cohort study that has 450 some people with Down syndrome enrolled in it now. And we have a lifestyle component to that study where we're trying to study some of these factors that we're touching on, right? Sleep management, not diet yet, but exercise, opportunities for socialization, cognitive stimulation. And we're doing sophisticated biomarker studies on those individuals. So our outcome is just not, did they develop dementia or not? We can look at the rate of change in the deposition of amyloid and tau, say, for example, in their brains with these PET scans that we're doing. And we had one result from that study that people with Down syndrome who are actively engaged in employment develop less amyloid per unit of time in their brains than people with Down syndrome who were not actively engaged in employment. And you think about employment, right? You're probably walking more, right? You're moving more. You're socially engaged more. You're certainly cognitively engaged more, right? So some of these factors we're now starting to get data to actually prove their benefits for people with Down syndrome. And I think it offers some hope to families. We think of Alzheimer's dementia as being inevitable for people with Down syndrome, something that's completely out of our control. Both in people with Down syndrome and without, we are starting to learn there are things we can do that might shift that needle a bit. Might not eliminate that risk, of course, but if we can just buy additional good years of good brain health, it's important. So we should all be mindful of those things.
Oh, and sorry, was that the slide you were looking for, or was it the
No,
one
I
after?
don't think so. She said the one after.
The one after anxiety.
Oh, okay, just go back.
That one.
This
Oh,
is
that one.
The
Okay.
tips,
That's it. Thank you. I'm just taking a photo of it.
good.
So next week, one of the things we plan to do, as I mentioned, the health.
Thank you.
Adults with Down syndrome were revised a couple of years ago. The revision included a change to the recommendation annual dementia screening for any adult with Down syndrome beginning at age 40 onward. That previous recommendation was there for many years, but it didn't give anybody a clue as to how you do that screening, because it's not an easy question to answer. But the latest guideline gave a recommendation, what tool to use, and that tool was developed by that national task group for best practices for dementia and people with intellectual disabilities. And that tool we will be reviewing because it's an informant-based tool that all of you can fill out. The most knowledgeable person of that loved one can fill out and take it to their clinician. How the clinician's going to interpret it is yet to be known, because it's not easy to interpret, but at least it's something, right? At least it's something. And you'll learn how that test, how that tool can benefit you, and then what some of the challenges are to it. But at least there's something there now. And I think where it's most informative is it guides anyone on the sorts of things they need, the sorts of changes they need to be mindful of. Right, at age 40, dementia is extremely uncommon, so you're capturing them at their adult best. And I think the interpretability of that test is much better when you've got subsequent measures to compare back to things.
Yeah, you've got your baseline, and then you can see when they take it again when you do it
What's
again next
changed?
year, what's changed, and you can kind of see the
Yeah.
pattern.
There's a pattern of change
Right.
that can be observed, but I think that's where it will fall. It'll fall on your shoulders to educate the doctors on this tool, which is the way it's going to be. But at least it's there. So.
Well, thank you all for coming, and those of you who are online.
Thank you.
welcome
Appreciate it.
next week, and have a good day. Thank you for being here.